Hello everyone. Once again, welcome to our channel, that is Emma's OG 3 Made Easy. And I've just, as I told you, we will be presenting a few cases to you, and so which are important. We selected cases which are important, and now they can be some obstetric emergencies also. They can be obstetric emergencies, including newborn. So here today, I'm going to explain about the maternal collapse. It is a structured discussion, and also followed by neonatal resuscitation. That also is a structured discussion. So both are obstetric emergencies. Now you need to know, the examiner will be asking you a few questions. Here your consult, the case scenario is in front of you. Now I'm starting with the maternal collapse. Your consultant will conduct a case-based discussion with you on a recent antenatal patient to assess your ability to manage similar patients appropriately. You're called to room number 5 to see a 30 pregnant lady, to see 37 weeks pregnant lady, and she is in room number 5, who is admitted with pain abdomen, who collapsed. We do come across such cases in our daily practice also, when when we keep taking rounds and all. Suddenly, one patient collapses in the room. And so, the how do you manage? So it is very important station for all of you, not only for the examination point of view, but for also your management, how you manage in that type of setting. So here you are an ST5 as on a labor ward call. Suddenly you will get a call like this. Then examiner will ask you a few questions. In this, he will not project the questions, like there won't be any questions in front of you. He'll be asking you. So depend what, and these may not come. These questions he may not ask. He will change the questions also. So overall, you need to know how to manage a maternal collapse, and what are their causes, what are the reversible and irreversible causes. So here, this in this station, we have given a few questions. That is, how will you manage this patient? What is the post-resuscitation care of this patient? And what are the reversible causes of maternal collapse? So these can vary. Okay. Now moving on to the station. So, so you are facing the examiner. So, hello, and I am Manjula. I'm Dr. Manjula, Part 3 candidate. I have gone through my case scenario, and I am ready to go ahead with the case-based discussion. So then he will say, how are you going to manage this case? Now that you know about this case, then you say, thank you for your question. Once you say, that's all. Thank you for your question. Now I can see that the woman under discussion is, she collapsed in her room, that is in room number 5. So this is maternal collapse, and it's an obstetric emergency. So if immediate and prompt actions are not taken, it will decrease the maternal morbidity and mortality. So I would like to quickly move to the room number 5. And first I would make sure that the woman is in the safe environment. Then I would stimulate and assess if woman is responding. If she is responding, then the patient is turned on to the left lateral position, because she's pregnant. So if you tilt her, and I'm sorry, I'm telling you, then the patient is turned on to the left lateral position. Now we have to call for help. We will call for help, and then we will I'll assess the vital signs of the patient. That is, I'll be checking her breathing and her pulse rate, blood pressure, and fetal heart. But then I will start the monitoring. That is my obstetric morning chart. I'll start the chart, and then after identification of the cause of the collapse, I need to identify the cause of the collapse. And after identifying the cause of the collapse, then the treatment will be towards this cause of the collapse. That will be started. Now, I will see, once I see that the patient is responding or not. So if the patient is not responding, if she is not responding, then I will be shouting for help. Then I will shout for help, because then I will call for the multidisciplinary team. I'll involve the multidisciplinary team, that is a cardiac resuscitation team. Then I'll inform a consultant, and then this midwife coordinator. So she will be coordinating with people whom I'm calling for help. Nurse, I'll be senior nurse. Then I'll also call the anesthetist, and then the neonatal team. So then also the porters to carry blood samples. And now the patient is already 37 weeks. So the multidisciplinary team is involved, and then I will be delegating the task. that is, I'll be taking the lead, that is taking the leadership, and also I will assign the task to my colleagues. That is one member. I'll assign the task of one member of the team to explain the situation to the family members, because patient anyway she's collapsed, she will not understand. So family members we need to inform. So one of the team member will do that. One person will be doing that. The second person of the team will do the documentation, and then I, taking the lead, I will do this cardiopulmonary resuscitation in the usual ABCD approach. First, I'll check with the A's. Well, first I will check the airway. That is by giving the head tilt and chin lift. So head tilt and chin lift, and if any obstruction is there, then I will remove it. Then I'll start the 100%. I'll start the 100% high oxygen flow at the rate of 10 to 15 liters per minute. And so this one of my colleague will do this. And then now this is the airway. Now I'll move on to the breathing. I'll assess the breathing. That is whether the patient is breathing or not. For 10 seconds, I will look for the breathing, whether look for the chest movements, and listen to the breath sounds. Then also I'll feel whether feel for the air, that is whether she's breathing or not. I'll feel with the finger for the air. So then if the woman is breathing, I'll put the woman in the recovery position or the left lateral position, and I'll make sure the help is coming. And then I will check the vitals, that is the pulse rate, blood pressure, and also the baby's heartbeat, and also check the respiration. Then I'll start one of our team members will be starting the early obstetric warning chart. Then we'll start then we will move on to, we'll start looking for the cause of collapse, and then we'll start the treatment accordingly. But if the patient is not responding, if she is not breathing, then we will start the cardiopulmonary resuscitation. That is the cardiopulmonary resuscitation team. By this time they arrive, and then so they will start doing the cardiopulmonary resuscitation. That is 30 chest compressions and 2 ventilation breaths. So this way they will do the chest compression. So here, then the chest is compressed around by about 5 to 6 centimeters. The chest is depressed. So 5 to 6 centimeters in the center of the chest. In the center of the chest, the pressure is applied, and so that the chest is depressed 5 to 6 centimeters and uninterrupted. Uninterrupted. So we give the 30 chest compressions with airway adjuncts. Here, we need two people. Two people are involved in this. So now, we do this till the patient is intubated. So till that time, it is the 30 chest compressions and 2 ventilation breaths. So 30 is to 2. Now, once she is intubated, then we give the 100 chest compressions per minute. Then, and with 10 ventilation breaths. So it will become 100 is to 10. So 100 compressions with 10 ventilation breaths. Then this is about the breathing. Then move on with one of the team member will check the circulation. My colleague will put 2 whiteboard cannulas and start fluid hydration. By giving the fluids, IV fluids, and blood samples will be collected. One of them will collect the blood samples. Nurse can collect the blood sample, and if the blood samples, if the patient is a case, or depending upon the situation, cause, that is, if it is preeclampsia, the blood accordingly the blood samples are collected. So, like for example, if it is a preeclampsia, then we take the full blood count, urea electrolytes, liver function test, blood group and save, and also we'll cross match 4 units. Then we watch the patient every 2 minutes. So then simultaneously we'll attach the defibrillator or the monitor which is attached. Now, and I'll assess the rhythm and see. That is then suppose if there is and check the heart rate. If there is no pulse activity, if there is no pulse rate felt, or if it is asystole, and the CPR, the cardiopulmonary resuscitation continue for 2 minutes. So then, if it is asystole, then we'll continue this cardiopulmonary resuscitation. And but if it is ventricular fibrillation or pulseless ventricular tachycardia, then we move on to give the shocks. That is, 2 shocks are given. That is 200 joules biphasic or 360 joules monophasic shocks are given if it is ventricular fibrillation or Tachycardia, pulse, ventricular pulses, ventricular tachycardia. Now, then when we are giving the shock, we need to be careful. That is, we will see that no one touches the patient or bed, and the oxygen, the CTG tracing, and should be away, will be away from the. We'll see that they're away from the patient, and then and the meanwhile the cardiopulmonary resuscitation will be continued. So after completing everything, if there is, then we will check whether there is any improvement. If there is no improvement, suppose there is no improvement, then we move on to giving drugs. That is adrenaline. We give every 3 to 5 minutes, and we also can consider giving amiodarone, atropine, magnesium sulfate, and see the response whether the patient is recovering. And if there is no improvement in 4 minutes after this cardiopulmonary resuscitation, we will quickly decide to go ahead with the perimortem cesarean section. That is, for the maternal sake. For the maternal sake, baby may not be surviving. So this is for the maternal sake. We are doing we are doing this perimortem cesarean section. It is done at the same site with one scalpel, and the patient delivered, so that, and then after that, then we will close it and move on to we'll shift her. Once she's stabilized, we'll shift her to the theater to complete the cesarean section. Then after that, once the cesarean section is complete, and then we will check her vital signs. Then then we'll find out what could be the cause for her collapse, and we'll treat the cause. Then this way we'll manage this patient with a maternal collapse. Now, the second question will be, the examiner will be asking the second question. That will be, what is the post-resuscitation care for this patient? So, we need to say, the patient will be in the, once the cesarean section is complete, and the patient will be shifted to the high dependency unit, that's HDU or intensive care unit, and her monitoring will be continued. Her vital signs are monitored. Her early obstetric warning chart will be continued, and then the oxygenation, the ventilation will be continued. We will keep a check on the temperature, pulse rate, respiration, and oxygen. All these things will be continued. And so, if we are able to, that is, once the patient is revived, and then so the care will be continued in the post-operative, in the intensive care unit, and then this is followed by the documentation of each step. We will, here in this, the multidisciplinary team is involved. Once again, here also her care will be under multidisciplinary team care. That is in the HDU also, and then we need to debrief her family members, initially her family members, her partner and family members, and once she recovers, we will debrief her also as to what has happened. Then then we also will debrief the staff members, that is what has happened to her, and the team, and then do the incident reporting and find out the root cause analysis. So then we will also find check for any disabilities also. So this this way we manage her, and that is the post resuscitation care. But on the other hand, if we are unable to save her, in spite of all these resuscitation measures, if we are not able to save her, we will be reporting to coroner, and then after that we will be documenting each and every step, debrief the family members, and then raise the incident report. That's a clinical governance. Then this is a very important, as this is a very important obstetric emergency, which is where if you're very trained, and the prompt treatment, timely treatment can save the mother. And so we need to have yearly life basic skills, then the skills and drills program about the resuscitation, maternal resuscitation. And so this way everyone has to be trained in this. So then root cause analysis will be done, and the steps will be taken to prevent. So this way I'm going to manage this patient. Now, then the third question will be, the examiner will ask you the third question. What are the reversible causes of collapse? So you need to say there are, we have got reversible causes like we say 4H and 4T. So one is hypovolemia. Hypovolemia is the it is bleeding, that is because of the hemorrhage. Because of the hemorrhage, it can be hemorrhage, obstetric hemorrhage, or any other hemorrhage which may be concealed, or which may sometimes may be concealed also, or it can be because of the hemorrhage, or it can be because of the spinal block. Sometimes suddenly they become collapse, or it can be neurogenic shock. So we need to find out that. So one is hypovolemia. Then second thing is hypoxia. Pregnant women can become hypoxic very quickly. So it's very important to prevent hypoxia occurring. And the common causes could be cardiac causes, that is peripartum. We need to think about peripartum cardiomyopathy, myocardial infarction, aortic dissection, and aneurysms. Large, aneurysms. So then the other cause could be hypokalemia or hyperkalemia. But then the other cause can be hyponatremia. This hyponatremia could be because of the oxytocin use. Then the hypothermia, which is no more likely cause. Now, moving on to the other four causes, that is thromboembolism. That is, it could be the embolism. Embolism can be amniotic fluid embolism, pulmonary embolism, air embolism, myocardial infarction. Then the other T is toxicity. The toxicity can be drug because of drugs, that is like local anesthetic or magnesium sulfate. And then it could be because of the tamponade, or it can be tension pneumothorax. These could be because of tamponade or tension pneumothorax, could be because of the trauma or such things. So, and other causes we need to think about is eclampsia, preeclampsia and eclampsia. So these are the things which are the reversible causes. And whenever we find out the cause, the treatment is directed towards the cause. So this way we manage the maternal collapse and identify the cause and manage the cause. Thank you for your time.